getting a copy of this lecture, and you'll find that there are some slides which I have hidden for today, but will be available to you, that are generally charts and things which you can peruse at your leisure. Even so, I think I've got too much information for what's now probably an hour and 20 minutes. So I will have to omit some of the information, but I'll do my best to cover as much as I can. So what I thought we'd start with is talk about different ways that we can image the liver, because this tells us a bit about liver imaging, but it will also tell you about the modalities, the basic fundamentals of the imaging modalities. So the first technique we would really use for liver imaging when someone comes in would be ultrasound, because it's readily available, it's cheap, it's safe. It's a good screening tool. It can pick up liver metastases, chronic liver disease, and it's an examination of first choice for jaundice, because it's a very good way of looking at the biliary tree. It's also, of course, very useful for interventional radiology, and we use it all the time for guiding liver interventions, biliary drainage, liver biopsy, either diffuse liver disease or secondary deposits. It has disadvantages. It's very operator dependent, and it doesn't give you complete tissue characterization. There's no hard and fast routine as to what images you take on ultrasound, so it's also difficult to compare one examination to another, which is different from CT. So generally, although it's the first examination, we'll need further imaging. So we go on to CT. CT is generally very good for detecting liver masses. And as I mentioned before, it's very reproducible. So because it's done to a fixed protocol, depending on the organ. And so you can compare older images very easily with current ones. We generally use intravenous contrast to maximize lesions in the liver. And there are various aspects of lesion enhancement that give us more information. One is the way that the lesion enhances with respect to time, but also how the lesion enhances within itself, the morphology of the lesion as it's enhancing. Disadvantage, of course, is that liver CT or any CT is using ionizing radiation, and there's a risk of inducing a second malignancy, although this is becoming less of a risk now because various modern advances in CT have reduced the dose considerably. So this is now a chance for me to just talk very quickly about CT basics for those of you who don't know too much about CT. As you know, we use an X-ray beam to produce the image. We shine the X-ray beam through the patient. We measure what comes out the other side. And we do this as an active process as the patient is moving through the machine and the X-ray tube and detectors are moving around the patient. This then goes into a computer which can work backwards and decide what the structure of the patient is in cross-sectional imaging to give you this pattern of attenuation. We present the imaging in what's called a grayscale. So the body is divided up into a lot of pixels, as we have in any digital imaging. In radiology, the resolution of CT is not high at all. So we generally use a matrix of 512 by 512. So nothing like your mobile phones, which give a much higher resolution. And then each square is given a value depending on how much that square attenuates the X-ray beam. So high attenuation or a lot of absorption of X-rays, we code on the image as light grey or white. Low attenuation or not much absorption, such as air, is dark grey or black. So there are a few fixed levels of attenuation. Water has an attenuation of 0, and HU stands for Hounsfield units. Sir Godfrey Hounsfield was the inventor of CT. Soft tissue slightly higher attenuation, 30 to 40 Hounsfield units, so that will be slightly lighter, less dark. Fat is less than water, so that will be darker than water. So already we've got a way of distinguishing most soft tissue from fat on a CT. And then air has a fixed attenuation of -1000, so air will be very black. So here's just an example with a cross-section of the abdomen at the level of the liver and the kidneys, and you'll see that air around the patient is very black. Fat is fairly dark, and it's darker than soft tissue. There's muscles of the abdominal wall, there's the liver, there's the kidneys. But the soft tissue is not as white as the bone. And bone, you can see that the cortical bone is particularly white because it's very dense and absorbs a lot of X-rays. Generally, if you're not sure of the level of grey of a particular structure, you're not sure what it is, you can go to something that you know. So for here, for example, is a bit of colon, and then we've got some dark bits. Well, it's as black as this, the air outside, so we know this is air in the colon. Okay, so let's talk now about contrast enhancement in the liver. For most abdominal CTs, we give iodinated contrast into a peripheral arm vein. On average, we'll give a dose of about 100 milliliters, and this is given through an infusion pump, which we can vary the rate, but on average, we use a rate of 4 milliliters per second. When we time the scans, we start the timing from the beginning of the injection. So we've got different phases. We can have an unenhanced scan, that's pre-contrast. We don't normally do that. An arterial phase at 35 seconds from the beginning of the injection, and that reflects the time it takes for the contrast bolus to flow from the peripheral vein through the lungs, through the heart, and into the arterial system. Then if we wait longer, another 35 seconds, this opacified blood will pass through the splanchnic circulation and then into the portal vein. So at 70 seconds, we have maximal portal venous enhancement. And then for various reasons, we might have a delayed scan at 5 minutes or 10 minutes. Okay, so one of the reasons that contrast is so good in showing lesions in the liver is that liver metastases have a different blood supply compared to the normal liver. With normal liver, you know, it has two blood supplies. It has an hepatic artery and a portal vein. The hepatic artery supplies only about 20% of the blood to the liver. Most of the blood supply to the liver comes from the portal vein. And so if we take, but the difference is that liver metastases don't recruit their blood supply from the portal vein, they recruit it from the hepatic artery. So if we take a portal venous phase image, the normal liver will be enhanced. And remember, enhancement means that the tissue is absorbing more X-rays due to the iodinated contrast within it than normal. So it'll be whiter. And therefore, most metastases will be shown as almost like a negative image because they will be relatively dark compared to the enhancing liver tissue. This doesn't follow with certain metastases such as neuroendocrine tumors, which are so vascular from the hepatic artery that they will actually hyper-enhance on the arterial phase. And HCC is a special case, which we'll see in a minute. So here's an example, a little schematic diagram. So here on the left, we've got the arterial phase in the liver, and so this is the hepatic artery, and the white is the contrast. And here we've got a hypervascular lesion, probably a neuroendocrine tumor, or maybe focal nodular hyperplasia, really lighting up. But here on the right, we've got the portal venous phase, and these are lesions which don't have a portal venous blood supply. They might have a hepatic artery supply, but see how easy it is to see them in the portal venous phase because they are negative filling defects, if you like. So here's an example of the venous phase. This is and if you look carefully, you can see you've got, these are normal bile ducts and venous structures in the left lobe of the liver. In the right lobe, that's been effaced by this big mass with some patchy calcification within it. Not very easy to pick up, but if you do a portal venous phase here, suddenly the rest of the liver enhances, and this big metastasis from colorectal cancer is much more visible because it's showing relatively no enhancement because it doesn't recruit from the portal vein. Okay, now we'll just deal with a benign liver lesion, hepatic hemangioma. This is very common, often picked up on ultrasound when you see it as a bright lesion, but you may see it on CT, and it will be low attenuation pre-contrast. If you give contrast, because it's a spongy, low flow lesion, it very gradually picks up contrast from its periphery, and it'll show gradually increasing peripheral nodular enhancement. And if you keep imaging over 15-20 minutes, it'll gradually fill in with contrast to be isoattenuating with the rest of the liver. So here we've got a hemangioma over time with a contrast enhanced scan. Here we've top left, we've got pre-contrast where you can see this low attenuation lesion in the right lobe of the liver. Top right, you can see this is the arterial phase because we've got contrast in the aorta, contrast in the celiac trunk, and here you're getting this slow peripheral nodular enhancement. Here on the bottom left, we've got portal venous phase. Notice we've got enhancement of the portal veins here, and you can see how the enhancement is gradually filling in. And then on, I think this is probably a 15-minute scan, and the whole lesion is filled in apart from a little central scar. When you compare this to the unenhanced scan, and this is a typical hemangioma, you don't need to go any further, you've proved it. Focal nodular hyperplasia is probably the next commonest benign liver lesion that we see, particularly in female patients. And this has a characteristic enhancement pattern. It shows marked uniform enhancement in the arterial phase. So this is one of the exceptions. Generally a central scar, and it will remain isoattenuating to the portal vein on the portal venous system, on the portal venous scan and on later scans. So here's an example. This is arterial phase. Notice the contrast in the aorta. It's a latish arterial phase because we've got some contrast in the portal vein as well, but this is focal nodular hyperplasia with a central scar and marked arterial enhancement. As we go on to the portal venous phase, it's losing some of the attenuation it had before, but it's following more or less the level of attenuation of the portal vein. And here on the delayed phase, again, you can see it's following the attenuation in the portal vein. So this is another lesion that you can be pretty confident on the enhancement pattern that this is focal nodular hyperplasia. So we've looked at morphology of enhancement and the time in which the lesions enhance. Another aspect we can look at is how quickly the contrast is removed from the liver lesion. This is what we call washout. This is of particular use in diagnosing hepatocellular carcinoma because hepatocellular carcinoma tends to be hypervascular on the arterial phase, but unlike the last two lesions you saw when there wasn't really any washout of contrast, HCC washes out at 10 minutes. And these features, together with another feature, which you'll see in a minute, can be sufficient to diagnose HCC without biopsy. But the important rider here is that this is in someone who's at high risk of HCC, i.e. someone who's got cirrhosis. So we'll have arterial enhancement, washout, and the third important observation is you'll have an enhancing capsule. And here's an example of an HCC. Here's the arterial phase. Notice the contrast in the aorta. Here is the arterially enhancing lesion. Then on the portal venous phase, already the contrast is starting to wash. And then on the later, probably 10-minute phase, you can see that the washout is almost complete. But if you look very carefully, you can see there's a thin white line here. So this is the enhancing capsule. So this is a Barn-Dor HCC. Now, it's very important to realize that many HCCs do not behave in this manner. So if you're lucky in someone who you suspect has an HCC to get this contrast enhanced pattern, you're home and dry, but there are an awful lot of HCCs that don't behave like this. So that's done CT, and we're going on to MR now. So MR is more sensitive in imaging liver lesions compared to CT because it has greater soft tissue contrast. By contrast, we mean the difference between the levels of grey between normal liver and abnormal liver. We also have multiple sequences in CT, whereas in MR, whereas in CT, the only thing that we can change is whether or not we give contrast and the time at which we image contrast, the contrast. With MR, we can get different images, the radiofrequency pulses into the liver. And so we've got various physical characteristics that we can weight the image for. So we've got the T1 and T2 time constants. We can do fat suppression, make fat dark. We can do in and out of phase images, diffusion weighted imaging, dynamic contrast enhancement, and we can do an MRCP sequence, and there are many other sequences as well. One of the reasons we can do all these different sequences is that without any harm is that it doesn't use ionizing radiation. So as far as we know, MR imaging is very safe. There are disadvantages. It doesn't depict calcification very well. It's less available. You need to request the correct type of MR for the reasons I've just explained. If you don't have the correct sequences, you won't get the right answer. And the studies take a long time to do. Frequently, they'll take 45 minutes, even an hour. And perhaps I should also add, they take a long time to report because you get many, many images to look at. So we talked about basics for CT. Now we'll talk about basics for MRI. The bread and butter sequences are ones which are weighted for T1 and T2. Just a little bit of background, whereas CT images are generated by how the body absorbs X-rays. With MRI, we are using something called magnetic resonance, a phenomenon whereby when substances are placed in a strong static magnetic field, certain protons or certain atoms will undergo what's called precession. They rotate at a certain speed or frequency, depending on the strength of the magnet. So for routine MR imaging, we use the resonance of protons, that's hydrogen atoms, and they are rotating at a particular speed for a 1.5 Tesla magnet. That's the strength of the magnet, and most MR systems are 1.5 Tesla. We have a frequency of, I think, about 67 megahertz. Those of you who know about radios will know that FM radio is transmitted on 88 to 108 megahertz. So it's just below the frequency of FM radio. So put the patient in the magnetic field. The protons in basically water molecules, the hydrogen atoms, start precessing in a certain way. Now we can add energy to these precessing protons if we zap in a frequency which is the same as the frequency of precession, but in a different angle to the angle of precession of the protons. So this pulse is just for a short number of milliseconds, and then we switch off this radio frequency field, and then the protons relax back and give out a radio signal in the same way that if you remember doing fluorescence in chemistry, you excite electrons from one energy shell to another. Then when the exciting energy is switched off, the electrons fall back, emit energy, and in that case, it's fluorescent light. In this case, these are protons, not electrons, and we're getting radio waves back. Depending on how we give the pulses, it depends on what sequence we get back. And just out of a matter of interest, those of you who've seen or had an MR will notice that you hear this pulsation, sort of like that. And those little banging noises are the frequency, the radio frequency coils switching on and off very rapidly. So that's the tissues being stimulated by the radio frequencies and then the signals coming off. So T1 is a time constant which depends on how the signal rises when it's when the protons are excited, and gives and the most important things to realize about T1 sequence is that water is always dark, low signal. So we call this low signal dark image, whereas fat is high signal or white. On a T2 weighted image, on the other hand, water is high signal, which is white, and fat drops in signal a bit, but it doesn't go completely dark. If there's any one pair of things you have to remember, is that on T1 water is dark, on T2 water is white. Okay, that's a difficult bit. So here are two cervical spines, what we call a sagittal view. On the left, it's T1. Notice the CSF is dark, and here on the right, there's T2, and the CSF is white. So generally, anything with water will be white on T2, and many pathologies have increased water content. So often, pathologies show up as white on T2. Okay, then when we deal with the liver, we've got another slight complication. Firstly, I should mention that in MR imaging, the equivalent to the iodinated contrast we use in CT is compounds containing gadolinium in a chelate, and when we inject it intravenously, the tissues behave in much the same way with gadolinium as they do with iodinated contrast on CT. So if we've got our, for example, our focal nodular hyperplasia, which I showed you, when you inject contrast on MR, it'll go white in the same way as when you inject CT contrast for CT, it goes white. So that's okay. But with MR, we can also get more fancy types of contrast agent. And for the liver, we have hepatobiliary contrast agents. They also are based on gadolinium, but the gadolinium is linked to a certain substance which is taken up by hepatocytes and excreted into the bile. And this is useful for lesion characterization. Also, it can improve lesion detection when you're looking for small metastases. But important right is it doesn't distinguish benign lesions from well-differentiated HCC. Remember that HCC is a continuum. Development of HCC is a continuum from regeneration nodules. So regeneration nodules will tend to be a bit hypervascular, as will well-differentiated HCC. And hepatobiliary contrast agents won't help that. In a poorly differentiated HCC, well, you will be able to distinguish the difference because they won't have hepatocytes. So the one we use most commonly is something called Primavist, which is gadoxetic acid. And there's also Multihance, which is not used so much. Primavist is easier because what we call the hepatobiliary phase, when the hepatocytes have taken up the contrast, occurs from 10 minutes. So you can do the whole scan in more or less the same time as you would with normal contrast. Whereas with Multihance, you can't do your delayed phase for an hour. So you've got to do your routine scan, get the patient out of the scan and put them back in. So that's rather time consuming. Okay, that was a lot to take in. Here's just a nice snow scene. I was telling Zach just before we started this lecture that the best and greatest radiology meeting in the world has started today in Chicago, the RSNA meeting. And I just tuned in to listen to the first lecture, and they said that it's snowing in Chicago. Well, this is Austria, in March, in a skiing resort at over 2,000 meters, where you're still assured of snow, even though the lower Alps are getting a bit iffy now with global warming. So we'll forget about global warming for a while and go back to some CT. So this is how to read an abdominal CT scan. And this is useful for radiologists and non-radiologists. It's really aimed more at non-radiologists. And in the old days, non-radiologists had to be proficient in reading chest x-rays, abdominal x-rays, obviously extremity x-rays if you're an A&E doctor. But now, and at first, CT scanning and MR scanning was thought to be the province only of radiologists, but it's so common now that it's really very important that all doctors should, working in acute situations, should be able to at least read scans a bit. So this is a quick aid memoir of how to go about it. And I should say, as a radiologist, we depend on, for instance, the acute abdomen, the surgeons having looked at the scan as well, because they have certain advantages. They've seen the patient, we haven't seen the patient, and they will have certain diagnoses at the top of their list. They will look specifically for those diagnoses. And as a radiologist, you always have to have humility, because you're not always right. And often a sharp-eyed surgeon can get you out of trouble when you've made a silly diagnosis and say, well, I was worried about this. If they're tactful, they'll say that. And then you say, well, let's have a look. Oh, you're absolutely right. So, but here are some of the things that are very important. Firstly, if you haven't seen the patient, you need to read the clinical details. And the corollary of that is, if you have seen the patient and you're requesting the scan, please give very good clinical details. Relevant previous history is always incredibly helpful. One of the common features is you might get someone with abdominal pain, you do a scan, you find they've got liver metastases, but no known primary. Then if you go back to previous history, you might find, for example, 20 years ago, they had a melanoma removed from their back. More or less, Occam's razor is very sharp, and you're often home and dry, and you can show off and say, well, I think it's melanoma metastases. Check that you're looking at the current scan. With modern PACS, it's rather easy to look at the wrong series. So just check the date. But look for the previous scans, because often if there's something that you're not sure about, you can look back to a previous scan, say 5 years ago, and it was unchanged then. You may not know what it is, but if it's unchanged over 5 years, you can more or less forget about it. You get various scans to look at on a CT scan. It's presented in various ways. And one of the ways it's presented in differing slice thicknesses, different reconstructions. Don't look at the very thin slices. Look at the thicker slices, because they're quicker to page through. They are better quality because you've got reduction of noise. And generally you reserve the thin slices for more detailed viewing. Always starts with the axials and on the soft tissue window. I haven't got time to talk about windowing really, but I expect you know that not everything you see on a CT scan, or rather when you look at a series of CT images, they're not optimized necessarily for what you want to see. So generally for abdominal imaging, we optimize for soft tissues, but you may want to look at bones, so then you should look at the bone windows, or you may want to look at the lungs when you look at lung windows. But generally for abdominal imaging, look at the soft tissue windows first. And don't get bogged down in details. Quickly scroll from top to bottom, and you may well see something obvious. You might see a pneumoperitoneum, you might see obvious bowel obstruction, and so forth. If you haven't seen anything obvious, then you have to go through this systematic analysis of the organs, of the abdomen, pelvis, thing. I won't read out all these, but when you look at colon, I find the easiest way is to think you're an endoscope, start at the rectum, and then by scrolling, work your way up the rectum into the sigmoid, and then you'll have to, you get the sigmoid loop, you'll have to come back down to follow it round to the junction between the sigmoid and the descending colon, and then you go up again. And if you sort of drive yourself around the colon, you won't miss anything. And it's surprising how often you can diagnose a colon cancer on just a simple CT. You don't necessarily need CT colonography. Few tips. It's much easier looking for fresh blood on a head scan than it is on an abdominal scan, because we can use narrower windowing on a head scan for technical reasons. So on a head scan, fresh blood is very easy because it looks white. But it will look whiter than ordinary fluid in the abdomen. You've just got to look slightly harder. So you can distinguish fresh blood from normal fluid. Fat stranding is something very commonly seen in pathology in the abdomen and pelvis. And it's partly because all the organs are surrounded by fat. And fat stranding is generally due to edema. And this is commoner in inflammatory conditions such as diverticulitis, appendicitis, cholecystitis, less often seen in cancer. So if you've got a lot of fat stranding, think inflammation. We do an awful lot of secondary imaging for reported dilated common bile ducts on ultrasound, but it's a very common finding, particularly in older people, that the bile duct does dilate a bit. And if the LFTs are normal and you're not worried about lesions that might affect the bile duct, generally, there's nothing to worry about. So think twice before sending someone for further imaging with just slight dilatation of the common bile duct. Remember that most gallstones are not visible on CT. This is one aspect where ultrasound has a huge advantage because ultrasound will pick up virtually all gallstones within the gallbladder. Splenonculi are common. They can look as little rounded masses adjacent to the spleen, same attenuation as the spleen. Don't necessarily say that they are, if they're adjacent to the pancreas, that they are pancreatic cancers. A little bit of free fluid is common in the pelvis in premenopausal women. And coronal reconstructions are useful in bowel obstruction because often you can see the point of obstruction much more easily on the coronal reconstruction. So just a few quick examples of acute abdomens on CT. Very easy because we've got letters marking the organ of interest, and here we've got P for pancreas, and you'll notice that here are the interdigitations of the surface of the pancreas, and the pancreas is surrounded by fat, but this fat is not like this fat here. This is a mental fat here. This is subcutaneous fat. It's nice and dark. This is lighter. Why is it lighter? Because it's got water in it. And why has it got water in it? Because the pancreas is inflamed. So this is acute pancreatitis. Here we've got A, and A is for abscess. How do we know it's an abscess? Well, firstly, we've got this very dark stuff here. And remember I said, how do we work out what something is if we're not sure on the attenuation? Well, this is as dark as the surrounding air to the body. This is air, and we've got a sharp interface between air and fluid. So this is an air fluid level. Here is the pancreas, and this is air and fluid in a shaggy walled cavity. It's not typical of a simple cyst because simple cysts have nice smooth walls. And this is a pancreatic abscess, again, a complication of acute pancreatitis. This is another section at the same level in a different patient. And the first thing to notice is there are all these white objects here in the region of the head of the pancreas. Why is it so white? Well, you could say maybe it's a vascular abnormality because the aorta is white. Yes, but no, I don't think so. We've also got another white structure here, and this is bone, calcium in bone. So this is calcification. So this patient has got chronic pancreatitis. With another complication of chronic pancreatitis, this is a cyst, smooth-walled with fluid attenuation within it. But there's a little wisp here of something else, and this is contrast going into the cyst, because we said there was contrast in the aorta, and this is a puff of contrast. There's bleeding into the cyst, and this is a complication where the hepatic artery gets involved in the chronic pancreatitis. You get aneurysm formation. It erodes into the cyst, bleeds into the cyst. If the cyst is communicating with the pancreatic duct, the blood will then pass down the pancreatic duct into the duodenum, on into the bowel, and the patient will present with melena. so-called Haemosuccus pancreaticus. Not common, but it does occur. Also upper abdomen, and this structure is the gallbladder. Why is it the gallbladder? Well, it looks like the gallbladder, it's gallbladder shaped, but it should contain fluid, shouldn't it? Well, fluid, we haven't got much fluid containing stuff here, but here's a little bit of bowel with fluid, I think. It should be that attenuation. It's not, it's black. That's air. So this is air in the gallbladder, and here the gallbladder wall has been split in two by air. So this is emphysematous cholecystitis. Upper abdominal CT again, someone who presented with fever, right upper quadrant pain. Here is the liver, portal venous phase, nicely enhanced, but in the right lobe of the liver, there's this big lesion with a lot of lower attenuation material, which if I could show you the stomach, you'd see that this was fluid attenuation, with a shaggy wall. The patient is septic, so this is a hepatic abscess. Now, this is where clinical history is very important, because this doesn't have to be an hepatic abscess. If the patient was not septic, then other differentials would include a complex hepatic cyst or a cystic metastasis. And not uncommonly, metastases can become cystic like this. So again, in radiology, we're guessing a lot of the time, and we're using a combination of looking at the imaging, but also using clinical acumen. And this is what makes radiology so fascinating, because it's not just about looking at images, it's also being a doctor and being a medic. Okay, here we've got something that I always think looks a bit like a fried egg. This is a contrast enhanced scan. You can see you've got contrast in the renal arteries. I think these are renal veins here, actually. So, and we've got this rounded structure with white bits on the outside. What are these white bits? Same as bone, calcification. So what calcifies like this? This is aorta, isn't it? This is an aortic aneurysm. Here is the lumen containing contrast, but here we've got a lot of darker material, and this is mural thrombus. Remember that the calcification in vessels is normally in the intima because it's calcified endothelium. So this is marking the wall of the aorta. This is within the lumen of the aorta. Now, sometimes you'll see that this mural thrombus will dissect, and some of the contrast will go through layers of the mural thrombus. Please don't, if you get this in the report, please don't think this is equivalent to aortic dissection. It's nothing of the sort, and it should not be mentioned because it only causes confusion. It's quite common for this blood clot to develop interstices where the flowing blood can get through, and it's not at risk of aortic rupture. Obviously, the size of this means that this aneurysm is at risk of aortic rupture, but dissection through the mural thrombus is not an important sign. Oh yes, I should have said that this part of the kidney has been involved in the aneurysm and has got no blood supply, so it's infarcted. Right, okay, we've moved from the upper abdomen down into the pelvis, and this is, I'll tell you for free, this is a female pelvis, and here we've got fluid in a tubular structure, which seems to be acutely angled here. This is a female pelvis. This is a typical hydrosalpinx, or in this case, I think this was a tubo-ovarian abscess because the patient was septic. So we can't really distinguish easily between pus in a tube and fluid in a tube. Okay, and now the right iliac fossa. Here is the appendix cut in cross-section. This is with contrast, and you'll see that the wall of the appendix is enhancing abnormally. There is a bit of bowel which is not enhanced to the same extent, so it's inflamed. And this is fat around the appendix, and it's getting misty and stranded. So this is fat stranding, edema of the fat. Look at that fat there. This is extraperitoneal fat there. That's normal fat. This is stranded. This is inflamed. So this is appendicitis. This curved line here is the peritoneum, and even that is inflamed a little bit. It's enhancing. So this patient would have localization by this point of the appendicitis to the right iliac fossa because you've got localized peritonitis. And here's just another example, a less florid appendicitis. This is longitudinal section through the appendix. Again, a thickened wall and some fat stranding, and that is the peritoneal reflection there. There's also a bit of peritoneal inflammation. Left iliac fossa pain, quite an easy one for radiologists. It's either a renal stone in an adult, or maybe a gynae problem, or diverticular disease with diverticulitis. And here is the descending colon. You've got your fat stranding, and this is acute diverticulitis. A more subtle one, this is the level of the head of the pancreas, or the uncinate process really, and this is duodenum with fat stranding around it. And actually this was a perforated duodenal ulcer, but there's no air at the moment. You don't have to have, if it's, and this would be a retroperitoneal perforation, you don't have to have free air. Dilated bowel, this is small bowel, central-ish appearance, and you can tell it's small bowel because there is collapsed ascending colon, and here's collapsed descending colon, small bowel obstruction from lingual hernia. Here's another case of small bowel obstruction, and here you can see you've got some dilated loops of small bowel, but also some non-dilated loops of small bowel. So you know now that there's going to be a point of obstruction somewhere within the bowel, and this calls for a careful search, scrolling through the images to see where you get your so-called transition point from the dilated bowel to the non-dilated bowel, and that will show you what the cause is. Frequently, you won't see a mass there, and it's an adhesional obstruction, but you may see a mass, you may see tumor. And this is just a pelvic kidney, which is enhancing much more than some of the other structures, because if you remember at rest, the kidneys have, I can't remember, is it a quarter of the total cardiac output? They're very vascular organs, as we all know. Okay, so another just palate cleanser. This is a nice EasyJet flight going over the Alps. Hopefully there'll be a bit more snowy than this. This is, I think, in August or September, I think, when there wasn't much snow on the Alps. Right, so how are we doing for time? We've done nearly an hour, so we're not doing too badly. I'm going to talk more specifically now about the use of imaging in rectal cancer.
Yes, Nick, can I just stop you for a couple of minutes? In the meantime, I just need to ask whether anybody has got any questions to ask, especially liver MRI or liver scans, and also general CT scan from the CT scan or abdominal CT scan. Please feel free to ask Dr. Nick Redding before we go to rectal cancer imaging. Anybody can ask questions. And we can go back and see those slides as well if you want to get a bit clearer view or clearer view. Anyone? And you have got any questions, you can actually put it in the chat box and I'll say, yep, who is there? Who is there?
Yes, sir.
Yep. What's your name?
So I'm Dr. Tanvir, orthopedics consultant.
Okay, good. Any questions?
Question. A little question, sir, to Nick, sir.
Yeah.
Yes.
How's about the visualization of the gallstone on abdominal CT?
It's not very good. Probably about 10% of gallstones can be seen on abdominal CT. Mainly the ones that are calcified. There's a subgroup of gallstones which are due to hemolysis, chronic hemolysis. We call them pigment stones. 50% of those calcify, so you would expect to see 50% of those stones to show up, maybe even more. And so in things like thalassemia or sickle cell anemia, you can pick up a lot of those. But in cholesterol stones that aren't calcified, it's very difficult to see them. Sometimes, because cholesterol is a fat, they may be darker than the surrounding bile, but overall, I would only say 10% of gallstones are seen on CT.
Yes,
Thank you, sir.
We used to remember that 10% of the gallstone is seen CT or even plain abdominal X-ray, and 90% of the stone in the kidney will be seen, and 10% will not be seen in the plain X-ray CT scan. So 90 to 10 and 90% not seen. So that's why you remember that. Any other questions?
Thank you, sir.
Thank you, Tanvir. Any other questions? Anybody else?
Hello, sir. Here I am, Dr. Sohili, consultant radiologist from Square Hospital. Can I ask a question?
Oh dear, yes, but I'm a bit nervous.
Sir, actually, I want to know, do you use oral or rectal cancer contrast in case of acute abdomen? Like small bowel obstruction or large bowel obstruction?
No, I would advise against it because you would use water-soluble contrast, and in obstruction, generally there'll be a lot of fluid in the abdomen, within the bowel. That will dilute the contrast, and it won't actually help, because when the bowel is dilated, you've got fluid which is more or less equal to water, so it will show as dark compared to the enhancing bowel wall. So all you're doing is changing the bowel contents from dark relative to bowel wall to white. So you don't gain anything. Now there is the discussion that I always don't like having about whether you should give oral contrast in a case of small bowel obstruction to see if it's a complete or not complete obstruction. Well, I personally don't think there's a lot of evidence to show that that really helps in decision making. The idea is it will help in decision making whether you watch and wait or not. I actually don't agree with this, but I don't think we've got time to talk about it now. I think the state of the patient is much more important than what you see on the imaging. But the only times I would give oral contrast in an acute setting would be if you're worried about a perforation in an upper GI case, certainly esophageal perforation, gastric perforation, maybe duodenal perforation, but beyond that, there's not really much need for it.
Oh, thank you, sir.
Two questions. One is from Hussein Rumi. How reliable is CT abdomen to rule out or rule in ischemic bowel in hypertensive patient?
It's a very difficult subject, and it depends what sort of ischemia you're dealing with. If you're dealing with chronic ischemia, giving you, for example, intestinal angina, then it's not possible. You might see a reason for the intestinal mesenteric angina, such as a compression of the SMA with a nutcracker type syndrome, or the crus of the diaphragm. That might lead you to infer that sort of situation. In terms of more acute situations, it depends whether it's arterial ischemia or venous ischemia. If I do venous ischemia first, if it's venous ischemia, what is very useful is the unenhanced scan, and that's where monoenergetic imaging or spectral CT can help you, because you can get a virtual unenhanced scan, because that may show you on the unenhanced scan submucosal edema, submucosal hemorrhage due to the higher venous pressure. And then, of course, arterial ischemia, you have to look very carefully at the enhancement pattern of the loops of bowel. When you pick it up, it's very, very useful. And we had a case only about a month ago of arterial ischemia due to a volvulus, and it was very useful. But I can't give you chapter and verse, but it is a case where if clinically you think there's intestinal ischemia in an acute abdomen and the CT is normal, then it's very important not to think that this excludes ischemia, because it doesn't.
Nadia, do you want to add anything?
Yes, I wanted to add. because we do a lot of vascular imaging as part of the job. So yeah, I completely agree with Dr. Redding that normal appearance of bowel on acute abdomen doesn't exclude ischemic bowel. But if you, it's a borderline finding clinically, and if you suspect ischemic bowel, and if you want to re-image in 24 hours just to see the evolving changes, we may be able to help you with looking at the change in terms of edema, appearance of edema or free fluid, or which part of bowel is involved. And the other important thing is you can definitely do CT for ischemic bowel, which everyone does usually, is to look for, to exclude other causes of acute abdomen, and also to look for causes of ischemia. It may be arterial thrombus, which may come from heart. I always go back to heart anyway. Or it may be venous thrombosis. So to delineate the cause of ischemia, or even inflammatory causes, other causes, we can give you a clue what is happening in the abdomen. So it is important to image. I think CT will be very useful, but as Dr. Redding said, it cannot exclude bowel ischemia. So that's negative predictive value-wise, it's quite low, but sensitivity is quite high when the changes start to occur.
Yes, I completely agree. As a surgeon, we normally diagnose by clinical assessment any ischemic bowel. It's very difficult. I'm not saying it's very easy to diagnose, but they have got a pattern that they don't have any isolated localized abdominal pain. Sometimes it might be right iliac fossa, sometimes it might be left iliac fossa. It can go anywhere. And the patient is much more sicker compared to the normal other inflammatory conditions causing the abdominal, acute abdomen or social peritonitis. So you have to have a very good observational power to see whether ischemic bowel is going on or not. And please remember, if CT scan shows no ischemia, it does not exclude your ischemic bowel. So have a look, either a laparoscope, put a laparoscope or a small laparotomy, and exclude the ischemic bowel if you're in doubt. Okay, last questions from Dr. Asfar is, any imaging technique to differentiate head-dominant pancreatitis or inflammatory mass from malignant transformation in the background of chronic pancreatitis? Dr. Nick Redding.
Oh, that's a very difficult one. Sorry, can you just read the first bit again?
Yes, they're saying any imaging technique to differentiate head-dominant pancreatitis, for example, inflammatory mass, from malignant transformation in the background of chronic pancreatitis. I don't know whether
that's a difficult one. Firstly, I would say that in my experience, malignant transformation of chronic pancreatitis is not common at all. I don't know if I see more than about one case. Focal pancreatitis, the head of the pancreas, Tanaka, again, that's not very common. You mustn't forget what we used to call groove pancreatitis, what's now called paraduodenal pancreatitis, which can affect the head of the pancreas. It's probably due to parts of the, it's almost like a forme fruste of annular pancreas, in that there's thought to be a bit of pancreas actually within the duodenal wall, which is particularly susceptible for developing pancreatitis. But in terms of you're faced with a mass in the abdomen, someone who's had recurrent pancreatitis, is there a malignant focus? Well, routine imaging, CT and MRI, is going to be fairly low sensitivity. With CT, you might see associated signs such as regional lymphadenopathy. Then, of course, if you've got metastases in the liver, you're much more likely to think about that. And then, of course, you could biopsy liver metastasis to confirm your fears. MRI, you've got the advantage of using diffusion-weighted imaging to look for malignant tissue, but again, it's not specific for malignant tissue. But don't forget, you could use endoscopic ultrasound to biopsy the lesion, and if you find, maybe if you've got areas that cause concern on the MR, maybe certain areas with restricted diffusion, you might then be tempted to do an endoscopic ultrasound and biopsy those areas. PET scanning, I don't have enough knowledge about PET scanning to give you a useful answer, but I would have thought it would not be terribly useful because inflammatory tissues will be hot on PET, as will malignant tissue. And as far as I know, there's not a specific type of PET scanning. Like with prostate cancer, you've now got PSMA PET, which is a specific prostate-specific membrane antigen imaging, which is specific for prostate cancer. I'm not aware you've got a similar agent for pancreas, head of pancreas, or for pancreatic tumors. So the short answer is that it would be a multi-pronged approach, but it would be difficult.
Thank you, Nick. So let's start rectal cancer imaging now.
Okay, yes.
More questions, we'll go back again later on. Yeah.
Okay, right. So rectal cancer. MR is the best imaging modality for staging, and we use the T2 images as the key modality. Remember we mentioned T1 and T2. And so the MR of the rectum with T2 weighting will give you the location of the tumor and the morphology, give you reasonably good T and N staging. You would need to do a CT scan as well to do the M staging. We'll show you some extramural vascular invasion, the relation of the tumor to surrounding structures, because it's good soft tissue discrimination. And it's pretty good for distinguishing the T3C, T3D, and the N1s and N2 tumors. Those are the ones which benefit from neoadjuvant chemorad. You can also use it to assess response to treatment, and there's now an increasing move towards watch and wait on small tumors which regress completely with chemorad. You can also use it to image local recurrence. So just to show you the superiority of MR over CT, here's a patient with a CT through the pelvis. There's contrast in the bladder. This is the rectum with the mesorectal fat, low attenuations we said on CT, but you can't tell what's going on there. You should see some air within the rectum. There isn't any, but here, oh, no, why didn't that? There we go. Here, with the equivalent on MR, you can see how much better the imaging is at the same level. It's more or less the same level. So here you can see the mesorectal fat, and this is a T2 weighted image. So the fat is fairly high signal. We've got the mesorectal fascia, this dark line going around the mesorectal fat. This is a male patient, so here are the seminal vesicles, beautifully shown, so you can see if there's invasion within the seminal vesicles. And here we've got a lovely view of the rectum. Now the thick dark line here is the muscularis. The high signal line here is submucosa, and the darker line here is the mucosa. This is normal from about 1 o'clock to 7 o'clock, but here in the top right part, this is all tumor. See, it's destroyed the submucosa, it's destroyed the mucosa, and it's destroying the muscularis as well. So you can see that CT hasn't got a hope in terms of looking at the primary tumor. You remember your TNM staging. Here is the T staging. So for rectal cancer, the T staging depends on how far the tumor has extended from the mucosa. So T1, it's going to submucosa. T2, it's going into the muscle. There's the muscularis propria. And T3 is when it's gone through the rectum and is extending into the mesorectal fat. And depending on how far from the subserosa it's gone, will give you the ABCD staging. Then we go to T4 tumors, when T4A is when it penetrates the visceral peritoneum, T4B when it's invading other structures. So here's a schematic diagram which you can look at leisure. So here is the T4A tumor, which has gone through the muscularis, and this is the peritoneal reflection, so it's involving the peritoneum. Here's the T4B when it's going into an organism, and here is the various T3 stages, depending on how far it's going through the mesorectum. The end staging is depends on the regional lymph node metastasis. N1 N1A is 1 lymph node, B 2 to 3 lymph nodes. N1C is if you've got a tumor deposit in the subserosa, the mesentery, or the perirectal tissue, such as the mesorectal fat. N2 is 4 to 6 lymph nodes, and N2A, N2B is 7 or more, and these are regional lymph nodes. So if you've got a distant lymph node metastasis, say periaortic, that counts as a metastasis. So M1A is a metastasis in one organ or non-regional lymph node. M1B is in more than one organ or multiple peritoneal metastases. This is not direct peritoneal invasion, this is separate peritoneal metastases. Remember that with rectal cancer, we divide it into low, mid, and high rectal cancer, and this depends on the lowest portion of the tumor, how far it is from the anal verge. So if it's less than 5 centimeters, it's low rectal, 5 to 10 centimeters mid rectal, greater than 10 centimeters high rectal tumor, tumor. So here's some examples. So these are sagittal T2 weighted MRI scans. This is a male patient. You can see the prostate gland there. You can see the seminal vesicles, the bladder. And here is the tumor. There is the sacrum. There is the rectum in longitudinal section. This is the tumor. And a line traced from the anal verge shows that the most distal tumor is at 11 centimeters, so it's a high rectal tumor. Here is a mid-rectal tumor. You can see this fairly exophytic tumor is 7 centimeters from the anal verge. And here, by contrast, is a low rectal tumor. It's only 1 centimeter from the anal verge, so it's actually extending into the anal canal. Now, some tumors of the rectum are mucinous adenocarcinomas, and mucin tends to give very high signal on T2 weighted images. And this example on the left is of a mucinous rectal tumor. And you can see how florid it is, whereas on the right, we've got a non-mucinous tumor. So here is the circumferential tumor of the rectum. There's the lumen, it contains air, it's dark. This is all tumor. This is the muscularis. And surrounding this, you've got the mesorectal fat. This is a female patient. I think this is the uterus here. So this shows the contrast between mucinous and non-mucinous, and we'll have a bit more to say about that in a minute. So the papers have shown that accuracy, sensitivity, and specificity for staging mid or high rectal cancer is pretty good. Not perfect, but pretty good. Now, low rectal cancer, I've got some slides in this presentation, but there is certainly not enough time to go through it now. So we'll have to do that. You'll have to look at that at your own pace. Just some MR examples of different T stages. Here we have axial section through the pelvis. This is the rectum. The dark ring is the muscularis propria. And here within the lumen of the rectum, you can see you've got a polypoid lesion. There is the stalk of the lesion, and here is the polypoid head. So this is a T1 or T2, i.e. either located confined to the mucosa or going into the submucosa. But as far as we can see, the dark ring of the muscularis is not invaded by this tumor. Here's T3C tumor. here is normal muscularis. There is air within the rectum. Here is this fairly bulky lesion extending way beyond the muscularis. If you follow the muscularis round, it comes to here, and then it's split by this is all tumor extending into the mesorectal fat, and on measurements, this worked out as a T3C tumor. Here's a T4A tumor. So this is the rectum. Here is fluid within the lumen. This is the submucosa. Here is part of the tumor. It's gone through the dark muscularis propria there. And this very fine black line here is the peritoneal reflection. And again, I've got more details of the peritoneal reflection in the lecture that I've hidden from view here. But remember that the peritoneal reflection comes down much lower on the anterior portion of the rectum than posteriorly. So if you've got an anterior tumor in the rectum, it's more likely to involve the peritoneal reflection and push it into the T4A T stage, rather than if you've got one posteriorly, because here is all the mesorectal fat. Now we're moving into the T4B tumors, which involve adjacent organs. This is a female patient, sagittal scan. There is bladder. This is vagina. There's the vaginal vault. And here you can see this very bulky tumor growing into the posterior wall of the vagina. Here we have an axial section. This flattened structure here is the vagina. The vagina on axial sections has this sort of flattened appearance. The thin line is the mucosa of the vagina. There is a tumor. There is gas in the rectum. Here is the tumor growing from the rectum into the posterior wall of the vagina. This is a male patient with a prostate gland. Normally, on T2-weighted imaging, the peripheral zone of the prostate gland is high signal. Remember, high signal is white. So there's normal right side of the peripheral zone. The left side, it's abnormally low signal. And this is due to this tumor here within the rectum growing into the left lobe of the prostate gland. And here is another male patient with the seminal vesicles. There is the rectum with the dark wall of the muscularis propria, the light mesorectal fat. Here we've got tumor that's burst out of the middle level of signal, burst out through the right side of the rectum. It's going into the mesorectal fat. It's involving the levator plate there, and it's going into the seminal vesicles. This is a T4B tumor. Another T4B tumor involving the bladder. This is bladder wall, bladder containing a little bit of urine, and this is a mucinous tumor, very high signal. Here posteriorly you've got sacrum, and this is a high rectal tumor, and it's growing into the posterior wall of the bladder. Notice the disruption of the posterior wall of the bladder. So this is a locally very advanced tumor. Okay, talk a little bit about extramural vascular invasion. This is something that the pathologists know a lot about, and it's only fairly recently that we've realized that we can sometimes pick this up on MR imaging. And the pathologists know that if there's extramural vascular invasion, it's a negative prognostic sign. It's not included in the TNM staging as yet, but it's something you don't want to read in your pathologist report. And it means that you've got tumor cells in vessels which are beyond the primary tumor, i.e. beyond the muscularis propria of the rectum. And you see it on MR generally as a loss of the normal low signal in vessels. One of the things I didn't mention is with MRI, vessels which have fast flowing blood or reasonably fast flowing blood give you what's called a signal void. And so the vessels look dark, generally they look dark. And if you lose that signal void, then close to a rectal tumor, then you start worrying about extramural vascular invasion. You'll also notice that the vessel will look fairly lumpy. It won't have the normal smooth shape of a normal blood vessel. So here's some examples. Here we've got two sagittal scans of rectal tumours. This is a fairly advanced mucinous tumour, both anterior and exterior part of the fairly high rectal cancer with fluid within the lumen here. And here is a vessel which is not as black as we'd expect it to be. And notice that it's all sort of a nodular wall as well. You might say, well, how do we know it's not as black as it should be? It's because we scroll through the images and we'd see that maybe on adjacent slices, you've got a normal vessel, which is very black. And here's another sagittal scan. Here is the sacrum. There is the tumor. And here is a big vessel. There's a little bit of flow void there, but here is tumor within the vessel. So that's EMVI. So low rectal cancer, there's not time to talk about it here. I will show you the detail. You can look at the details when you look at the presentation. Quickly, end staging. We mentioned this before, and we mentioned M staging as well. How do we stage nodes on MR imaging? Well, in the old days with CT imaging, all we had to go on was the size of the node, and we'd talk about the short axis diameter. You'll remember a lymph node is sort of a bean shape, so it has a long axis and a short axis. And we used to use a short axis diameter of 1 centimeter or greater to say that they were probably involved. But that's a very crude assessment because you can have nodes of normal size which will have tumor in, and also enlarged nodes in the presence of cancer may not be due to the cancer itself, they may be due to the immune response by the body. So now on MR, because of its greater tissue, soft tissue contrast, we can look for other features. So we can look for mixed signal intensity within the lesion. We can look for irregular margins as well. Here's a normal lymph node in an MR, oval shaped. Don't worry about this dark and white line. That's something called susceptibility artifact, chemical shift artifact. Don't worry about that. Here, in contrast, this is a very magnified image, but this is the rectum here. There's a big tumor here involved in the rectum. And here, you've got an obviously irregular shaped node with heterogeneous signal. And notice also that the signal looks very similar to the signal from the tumor. And that's another thing that can help you when you're looking for malignant nodes. Restaging post-chemorad. Tumor tends to lose signal after chemorad, and it's due to atrophy of the tissues and fibrosis. But you may get another change. You may get mucinous change within the tumor. So a tumor which originally was not mucinous, i.e. not high signal on T2, may, as a response to treatment, may become mucinous. And this is a good prognostic sign. Also, the submucosa may show increased signal due to edema as an effect from the radiotherapy. So we'll now quickly talk about the mucinous responses. So if mucin appears after chemorad, it's due to colloid degeneration and it's a response to treatment and it's a better prognosis. In tumors that are already mucinous pre-chemorad, they may change histologically to become acellular. We can't see this on imaging, but it can be seen on histopathology, and that doesn't actually have any impact on recurrence-free survival. The mucinous tumor that is mucinous prior to chemorad that does not respond to treatment, i.e. it remains mucinous and doesn't shrink, has an increased risk of local recurrence. Problem of whether what we're looking at is residual tumor or fibrosis can often be tumor. It can often be difficult because residual tumor has a lower signal than the primary tumor. Fibrosis and scarring can have a similar signal, but it generally tends to have much lower signal, but it's not easy to distinguish one from the other. Diffusion weighted imaging can help, and I'll just talk very quickly about diffusion weighted imaging because it is a very useful MR technique. It's a way of looking at the Brownian water the Brownian motion of water molecules. You'll remember from your physics that Brownian motion is a small movement of molecules in various spaces. You probably looked at it with smoke particles in a sort of a cloud chamber. Anyway, it's known, we can show with great accuracy how water molecules are moving amongst the tissues, both extracellular and intracellular, by using diffusion-weighted imaging on MR. And the basic concept is that if you've got restricted diffusion, the image of that area will be white, and if you've got free diffusion, it will be dark. Sorry, gone the wrong way. So here we've got tumor in the rectum on a T2 weighted MRI, sagittal, axial scan, and on diffusion weighted image, the signal is high, and and why do you get restricted diffusion? There's several reasons in malignancy. You get it due to the fact that there are often more cells than normal within a given volume, so that restricts the diffusion of water molecules in the extracellular space because there's less extracellular space, but also intracellularly, the cells are more complex. They've got more bits within inside them, and so the intracellular diffusion is also restricted. Now here, so this is pre-treatment, so the whole tumor shows restricted diffusion. Post-treatment, this is the T2 weighted scan. It's looking a lot better. I should have had these all in one scan. So there is a tumor pre-treatment. Here, post-treatment, we're beginning to get normal rectum appearing again. But if we look at the DWI, you'll see there's still a crescent of restricted diffusion. And here, this is the apparent diffusion coefficient map, ADC map, which is the inverse of the DWI, but it's less susceptible to artifacts. So if you can show that what you think showed restricted diffusion on the DWI imaging, if you can show that on the ADC map it does indeed have low signal, then you're much more happy to say, yes, this is residual tumor. So that's DWI imaging for you. So how accurate is staging MR post-chemorad treatment? Well, it's less good than pre-treatment. And so it's important to use a multimodality approach. So you'll do the MRI, but you also have clinical assessment, and you can do endoscopy to look for residual tumor. As a rule of thumb, with the nodes, the local nodes, if they've reduced in size by greater than 70% on imaging, or have a short axis diameter of less than 2.5 millimeters, we can be fairly confident to say that the nodes are now negative. Local recurrence, risk factors, lack of pre-op chemorad or radiotherapy, positive circumferential resection margin, which I'm sure you know about, extramural vascular invasion, close proximity of the tumor to the anal bulge, so a low rectal cancer in other words, perforation of the tumor at the time of surgery, an anastomotic leak, higher TNM staging on pathology, or a poorly differentiated tumor. Those are the things that increase risk of local recurrence. Most patients with local recurrence will have an elevated CEA. The commonest site will be the anastomosis, so we look very carefully at that on imaging. And MRI is the best imaging modality to detect that. As I mentioned before, it's difficult to differentiate between post-treatment changes from local recurrence. Both may be PET positive, but clues may be an increasing size over time, marked enhancement, and asymmetry, whereas normally fibrosis tends to be fairly symmetrical. So that finishes rectal cancer. We're running out of time, really. Here's a picture of Tuscany. Over there is a hilltop city called Volterra. Those of you who know about Tuscany will know it's got Etruscan roots, very interesting city, close to San Gimignano. Zach, I've already gone for about an hour and a half. Are we running out of time?
Absolutely brilliant. Thank you very much. I know that's a massive subject. you cannot just
Yes.
finish it within 90 minutes. But
No.
I've got a couple of questions to go through, and then I'll definitely ask some questions to the audience. And then, of course, we have to conclude. The one question is rectal cancer is better to see by MRI scan in early stage or in advanced stage of rectal cancer? And he also added that whether endoscopic ultrasound provides delineation in early or advanced stages of the disease.
So I missed the last bit. Does what
Dr.
show
Imran.
better?
Whether the endoscopic
Oh, yes.
ultrasound
Yes,
or
I didn't have time
EUS
to, yes.
provides
Yeah,
better.
that's a very good
delineation.
question.
Yeah.
I didn't have time to mention endoscopic ultrasound, but for T1 and T2 tumors, endoscopic ultrasound is very useful. It's difficult because you need a dedicated machine. You need something with a 360-degree probe, and it's a technique that you have to do a lot of to get good at it. But the advantage of endoscopic ultrasound is primarily that it has a very high resolution. Ultrasound, because of its physical principle using ultrasonic waves, can have a much higher resolution than MR. MR and CT are basically quite low resolution modalities compared to ultrasound. So you can have exquisite details, but the disadvantage is that it doesn't have much penetration. So you will not be very good. You won't be able to do the T3 stage, the T3 tumors at all. But yes, for T1 and T2 tumors, provided you can reach it, endoscopic ultrasound has some unique advantages. Yes, so and MR is certainly better for the more advanced tumors.
Good. So you got your answer, Dr. Asfad. Now, we have got Professor Colorectal Surgeon, Professor Shahadat Hussain Jantu just joined in. I'm sorry that I couldn't actually invite him earlier. Do you have any question at all, Dr. Shahadat Hussain Jantu?
Oh, Jakarullah, thank you very much. But
thank you for joining.
I joined for the last 15 minutes. That was very excellent discussion, but it would be very good if I could join from the beginning.
It was my fault. I remembered to text you, but I told you to remind you anyway. So do you think we'll try again? I mean, Dr. Nick Redding is going to leave all his slides for us to go through with all these key points in it. So it will be helpful for his students to go through his slides. I'm sure that will give a precise idea. And if you've got any questions, don't hesitate. I'm sure he'll be able to